abdominal and genitourinary trauma. Remember, we got to use our decap BTLS when we're evaluating the patient's deformities, eviscerations, contusions, abrasions, avulsions, amputations, penetrations, burns, swelling, lacerations, tenderness. As we look into the abdomen is protected by the skin and soft tissue on the outside. We have muscles that line over that to protect it, but basically there's no other housing or large structure that mechanically protects it. So that means that the intestines and abdominal organs may be prone to injury, especially from some type of frontal or anterior insult. So here's what we talked about as far as the decap BTLS. Eviscerations are not necessarily pertinent when you're looking for the chest or the head or an extremity, but more of the abdomen. Here we have the intestines that are protruding through the abdominal wall. It's been spewed out, and basically these intestines are packed so tightly inside the abdominal cavity that if there's a nick to the external wall, pulling the object penetrating trauma back out will cause the intestines just to spew out. This is evisceration. Management of the evisceration is to manage your trauma patient, and you do your trauma assessment, started with determining the number of patients, mechanism, and so forth, and then using your general impression, primary assessment, and move down to your focused assessment and delegating vital signs and the history being done. But we're going to try to cover this with a moist sterile dressing so that this intestine doesn't stick and become adhered to any of the dresses we put on there. We also don't want this to be incarcerated, trapped, or strangulated so that the blood flow to this eviscerated bowel dies off. So this is evisceration. The intestine is spewed through the abdominal cavity. All right. This person is in what's called a fetal position, but for us this would be more a right recumbent position. His knees are drawn up. It's just to reduce the pressure along the abdominal wall and relax the muscles on the abdominal area. He would probably fend better if you laid him supine with the knees drawn up and something padding underneath the leg. This point, I'm not exactly sure if they're lying them that way because they're worried about vomiting, but they are not necessarily looking at the patient's injury site. They both have their heads down and looking in other areas. But again, so the fetal position is usually the position of comfort for your patients. Here's our assessment. Remember, use your trauma assessment, determine mechanism, determine the number of patients, determine whether or not additional personnel, ALS equipment is needed, determine C-spine. Then as you get there, with your BSI and scene safe, and you're done with the determinants, you have a general impression of what the patient looks like, what are they doing, where are they sitting, what's the environment they're in. Then are they awake, alert, oriented, are they unresponsive, are they responding to you verbally, the AVPU orientation, name, date, and place, airway, breathing, and circulation, rate, quality, rhythm, and control any bleeding, skin color, capillary refill. And we're just treating the life threat. So if the airway is not open, open the airway, provide an airway. If the breathing is not established, reestablish the breathing with a bag valve mask or some positive pressure device. If breathing is adequate but oxygenation is low, provide supplemental oxygen. Control hemorrhage by putting on the tourniquet and dressings. And we keep moving forward. We then do a focused exam, and using the head to toe, we use our decap BTLS. All right. Here they're just showing us that normal breathing patterns for an adult is usually about 10 to 12 breaths per minute, and pediatrics is a little bumped up more than that, 12 to 20. If the pulse oximeter is less than 95, then we want to give some oxygen. And here's our flow diagram if you're so inclined to follow this. It's similar to our National Registry skill sheet, but it follows in bubble form. All right, please study your lecture notes, study your lectures, study your PowerPoints, study your book. Look over the chapter. Remember, with abdominal wall injuries, if it penetrates through the abdominal wall, we can have eviscerations. If it penetrated through the abdominal wall, remember high, medium, and low velocity type injuries. We can have lots of cavitation and cavitational injuries because of high pressure, high velocity. With our low velocity weapons like a stabbing, a knife. We have this cone of injury. And so really take a look. In the abdominal cavity, we have a lot of bleeding. And we can go from class 1 type of hemorrhage to class 4 relatively quickly because there's so much space. And as the blood fills up in the abdominal cavity, the belly gets quite distended, it gets irritated, and we have peritonitis. Right now, solid organs bleed. What are the solid organs? Liver, spleen, and then the retroperitoneal area, or the place behind the abdominal cavity. Kidneys, we have hollow organs. These hollow organs don't tend to bleed, but they can spew out contents that can cause peritonitis. These are like the gallbladder, the small intestines, large intestines, and then the stomach. All right. Keep studying.